it's really great to be here. And I think, being able to have something like this is just fantastic. It really represents how much sex differences research is happening at Stanford, even within the Division of Cardiovascular Medicine. And I wanted to highlight, I'm sure it's already been said, but a lot of this couldn't have been possible without philanthropic giving. There isn't necessarily money in the university for programs like this, and so it really comes out of passion from people like Dr. Stefanik and myself, as well as people in the community that ultimately give money to support this. So as you know, many of these seed grants that were being presented were supported in that fashion and wouldn't have been possible in addition to this program itself. So I just want to highlight that that's important for ongoing growth here in terms of these very important topics. So the work that I'm going to present was mostly sponsored through the NIH, but I will say that a lot of the analysis and getting the data out there has been, again, through postdoctoral fellows, so, and they're, again, supported also from philanthropic giving. So this does ultimately affect our next generation of trainees, too, and is very important. So I guess I should introduce myself. You're all like, who is she? So I'm Jennifer Tremmel. I'm the medical director of the Women's Heart Health Program at Stanford, and I'm an interventional cardiologist. And I obviously take care of a lot of women. Our program's now seeing a couple of thousand women per year. And one area of interest to me is women that have chest pain, but their arteries look perfectly normal. And we typically think chest pain's coming from blockages, but that's definitely not always the case. And so my research has been looking at what's going on with these patients and how, if in any way, are women and men different in this regard. So angina, again, chest pain felt to be coming from the heart, is very common. It's estimated that 10,000 million Americans have angina. When we take people to the cath lab to do an angiogram to look for blockages, it turns out at least 20% of patients do not have any blockages and their arteries look fine. And traditionally, physicians will lean over and say, well, you're fine, and reassure them there's nothing wrong with their heart. But in fact, these patients don't actually feel better after being reassured. They continue to have their chest discomfort, and they basically don't know why. And so one of the things that we're trying to get out to not only patients but even physicians is that having normal coronary doesn't mean that you actually have a normal heart, and that angina is not simply from obstructive coronary disease. And the patients who are most affected by this are women far more than men. So if we look at angina in and of itself, this is a busy slide, but it's all to say that if you look worldwide, far more women than men have angina. That's true in the United States as well, where we have a sex ratio of about 1.4 women to men having angina. The other thing that we see when we look at women and men is that women are far more common to have normal-looking arteries when they come in with angina. And this is actually true across the spectrum of coronary disease. So does this work? Anyway, we see that if we look at ACS, if we look at unstable angina, or patients that are actually having a heart attack, women are far more likely to have normal-looking arteries than men. What I'll be talking about today is stable angina, so patients with kind of chronic chest pain, and again, women are far more likely than men to have this problem. The WISE study, which was the Women's Ischemic Syndrome Evaluation, was very pivotal in lending us some insight in terms of what might be going on here. And so they found that women frequently have evidence of endothelial dysfunction within their vessels, which I'll explain further, also have evidence of microvascular dysfunction. And if you look inside the artery, that they may have a lot of diffuse atherosclerosis, so plaque that's not actually obstructing in one place, but is throughout the vessel and may be limiting flow. And they've also shown that this isn't a benign pathology. So having normal-looking arteries in chest pain can actually be associated with long-term cardiovascular events as well as cardiovascular death. And more specifically, if we look at these patients, we know that at 5-year follow-up, these women will report similar frequency of typical angina compared to those who have obstructive disease. Nearly half of them will have functional disability as well. That's not much different than women who have obstructive disease. At 1 year, Women who have angina but normal coronaries are almost twice as likely to undergo a repeat angiogram or have a hospitalization for their angina than those who have obstructive disease. 20% of them are rehospitalized for their angina within 5 years, and they have a 5-year annualized cardiovascular event rate that's 16% compared to 2.4% in healthy controls in the population. And ultimately, they cost a lot of money as well. So, greater than $750,000 compared to $1 million for a woman who has obstructive disease. So much higher than we would expect. And a lot of this is because they go to multiple doctors, they get multiple tests, they have repeat angiograms, and nobody can find anything wrong. And so it ends up being a drain on the system. And if we can figure out what's wrong with them right up front, hopefully we can stop this cycle of testing and spending. So in addition, if we look at these entities more specifically, we know that endothelial dysfunction will predict future cardiovascular events. And so patients who had endothelial dysfunction have a worse survival as well as cardiovascular events than those who don't. And similar for microvascular dysfunction specifically, those with microvascular dysfunction have worse outcomes on these entities than those who have normal microvascular function. So one of my biggest questions was, what about sex differences? So the WISE study was strictly a study of women. And out of the WISE study, kind of unfortunately came this idea that, women are more likely to have microvascular dysfunction than men. But we can't say that if we didn't study men. And so I really thought we should look at men as well. And also with the understanding, which is the basis of all this research, is that if we figure out something about one sex, we certainly are helping both sexes, because these are clues as to what might be going on in terms of underlying mechanisms and how we might focus treatment. As I was writing this grant initially, one study came out about sex differences. So there's one study that gave us a little bit of insight. This was out of the Mayo Clinic, Amir Lehrman's work. And they looked at these same variables. They looked at first atheroma burden, or how much plaque a person had. And they found that men had more plaque than women, which isn't something that was surprising to us. They also found that men had actually a longer length of endothelial dysfunction than women did. And then they found that women had more microvascular dysfunction than men, at least by how they measured it, which was CFR. And we'll talk a little bit about how this is measured and what this might mean. So on that basis, I want to kind of just go through what are each of these things before showing you what we have found so far. So endothelial dysfunction, quite simply, is where the vessels don't do what they're supposed to do. And we know from historic studies that if you put acetylcholine on myocardial cells, that they will, if they're normal, they're actually going to dilate. And if they are abnormal, they'll constrict. And they found that those that had been denuded in some way, that those endothelial cells had been disrupted, will do the opposite of what they're supposed to. And so this drug, acetylcholine, that would normally make the vessel dilate, will actually go to the smooth muscle cells and cause a constriction. And so we can use acetylcholine right in the coronary arteries in the cath lab and look to see, are people's vessels dilating or are they constricting, representing endothelial dysfunction. And so this is what we do in the cath lab. So this is a normal coronary artery, or at least normal appearing. So this is the LAD coming down here, which is the vessel we'll focus on. And then we give acetylcholine. And what you can hopefully see is that the vessel actually looks even a little bit bigger. So this is a normal response to acetylcholine and represents someone with normal endothelial function. Here is another patient. The LAD coming down here looks quite normal in terms of no blockages. We give acetylcholine in this patient, and what we see is diffuse constriction of this vessel, so abnormal endothelial dysfunction. And you can imagine that if this patient's exercising, her vessel's supposed to dilate, but in fact, something like this is happening and she gets chest pain. So the second thing is microvascular dysfunction. Microvascular dysfunction is occurring at a level we can't see in the cath lab. These vessels are too small, and we don't have any direct way of tapping into those microvessels in a real live person. And so we use indirect methods to measure microvascular dysfunction. The two most common are CFR, coronary flow reserve, and IMR, the index of microcirculatory resistance. CFR has been around a long time. IMR was derived by Bill Fearon, who's actually going to talk to you guys later, and is thought to be a more direct measure of the microvasculature. These measurements can be made in a couple of ways. One is with a Doppler flow wire, which looks at flow velocity and tells us kind of the difference in flow down the vessel when we stress it versus rest. And the other way is a thermodilution wire, which basically measures flow by looking at temperature changes as the saline goes down the vessel. At Stanford, we use a thermodilution method more often. Probably either works fine. There's some differences between them, but just to say that they do measure flow in different ways. So when you look at CFR is basically looking at flow down this vessel at rest versus flow when we create hyperemia. And we do that with adenosine, which is endothelial independent vasodilator. And we're looking at this ratio. CFR assumes that there are no blockages in the vessel, because if you're looking at the flow and you're curious about the microcirculation, you obviously can't have something in the epicardial vessel that would distort this value in terms of the microcirculation. If you do IMR, what we're looking at, it's kind of a variation on Ohm's law, and we're really focusing just on this microcirculation, and we're curious about the resistance. And this wire that we use measures both pressure and flow, and so we can measure pressure, and when we can measure flow and basically come up with resistance. So a normal vessel is going to have very low resistance in that microcirculation, so that when you exercise or you're stressed, those small vessels will open up and let the blood flow into the heart muscle. And then if you have high resistance, you have microvascular dysfunction, and basically that flow can't get there well, and you get angina. So all this comes out on a like a little reading for us. And so we can do the calculations, but basically we put saline down the vessel at baseline, and we do it again at hyperemia with the adenosine, and we can calculate how these flows are. So we basically just do that ratio, and we get CFR, and then we can calculate the IMR by looking at the pressure and the flow and coming up with a resistance. Also, when we do this, we get FFR, which measures a gradient in the vessel, which leads us to the next thing that we're interested in, which is there diffuse plaque in there that we actually can't see on angiography? So is the vessel not actually as normal looking as we think it is? So when we do angiography, basically all we see is the lumen, which here is represented in red. And if there's plaque in there, and it suddenly builds up in one spot, then we get a narrowing in the lumen. And so we say, oh, there's a 70% narrowing, needs a stent. The problem comes is if a person has very diffuse plaque in their vessel, which would just make the lumen look small, and this could be the exact same diameter as this one, but it doesn't look so bad because the vessel around it is also diseased. So it can be deceptive, and you maybe just see a small vessel, but you don't see one spot that's the problem. But if you measure the pressure in here, there's the same decrement of pressure in this vessel that has a focal lesion versus one that has all this diffuse disease. The issue here is there's not any place to put in a stent to fix this problem. So this is where FFR comes in handy. It's with the same wire, and FFR is basically measuring a pressure gradient across the epicardial vessel. And we use the traditional FFR less than 0.8 to represent a low number, less than you would expect in a normal vessel. A normal vessel would have no pressure gradient and basically would be at 1. So this is an example of a patient, 68-year-old man who was having typical angina. He had 2 negative stress tests. This is his angiogram. And basically you don't see any focal plaque here. So it looks kind of normal looking like all the others. But when we did his FFR, we got 0.53, which is certainly much less than we would expect in a normal looking vessel. His CFR and IMR were actually quite normal looking. We did a slow pullback with this, so when we do that pullback, once you go across a tight narrowing, you'll often see a jump. And in this patient, it's very steady, which would represent, again, that he just kind of had diffuse plaque all through that vessel. And then we look with ultrasound inside the vessel, and we can see this is atherosclerosis here, and these patients generally have diffuse plaque that's pretty circumferential all through the vessel. And so ultrasound is one of the last things that we look at when we do all these analyses, and we can measure lots of different measures of plaque, as well as what I'll show you next, which is myocardial bridging. And myocardial bridging is something that kind of came about in doing this research study that we hadn't necessarily started looking at in the beginning. And myocardial bridging is a congenital variant where the vessel, instead of lying on top in the epicardial fat, actually has myocardium that overlies it. And so what happens is every time the heart beats, then the vessel gets constricted in that spot. And this is actually quite common, so probably about a third or more of you in the room have it, and in most people it's completely benign, never causes an issue. But in some people it does seem to cause chest pain and even sudden cardiac death. So it has a wide range in terms of the clinical ramifications. It's most commonly found in the LAD, which is the vessel I've kind of been highlighting to you. Here you can see it right there. Do you see that winking? Sorry, these are supposed to cycle, but you can see the vessel squeezing right there. So that's a myocardial bridge. So we don't always see them on angiography that nicely, but we do see them on this IVUS, so intravascular ultrasound. And what we see are two things. One is we see this band, we call it a halo, and that's basically that myocardium overlying the vessel, and that's not normally there. And the other thing that we see is compression. So this is the vessel during relaxation of the heart, and then this is during constriction, right? So the vessel goes like this on IVUS, which you don't normally see. So to the research, now that you kind of have the background, so we wanted to go beyond Ys, and we wanted to look at men, and we also wanted to do a really comprehensive evaluation of these patients. So this is the most comprehensive sort of evaluation you'll see anywhere in terms of all the testing we did. We've done over 200 patients with chronic stable angina of unclear etiology. The majority are women, just by virtue of the fact that women have more angina with normal coronaries. Each of the patients had a coronary angiogram. They had endothelial function testing, microvascular testing, which included the IMR and CFR. They had FFR, looking for this diffuse disease, as well as IVUS, which looked at disease and myocardial bridging. We did not do patients that had significant obstructive disease because we weren't interested in that. We didn't do patients who were unstable in any way. They all had normal heart function, and they didn't have any other cardiac problem that might cause chest pain that would confound this. All these patients had angina, as I said. 62% had typical symptoms. The remainder had atypical symptoms. The ones with typical symptoms were a little more commonly women. And then almost all of them had also undergone stress testing, with 73% having abnormal stress tests, but still almost a quarter having very normal appearing stress tests, and some of them having several of normal appearing stress tests. And then we had a few that went straight to angiography with no stress testing. And one of the things that we've looked at is stress test actually helpful in identifying these abnormalities that I've been showing you. And so far, we've actually found no correlation. And stress tests just may not be sufficient to pick this up. Stress tests are really designed to pick up obstructive disease that's probably affecting the transmural myocardium, and these things are probably just affecting the epicardium, and a small layer in a stress test isn't enough to show that. This is our table 1. You can see the patients were on the younger side, and mostly female, as I said. There was a little bit more hypertension in our female group. The patients were on drugs, statins equally, but women were a little undertreated in terms of their LDLs were higher and their total cholesterol were higher. These drugs, any of the vasoactive ones, were held 48 hours prior to the tests being done, because obviously that could mess up these tests. So what we found when we looked at the entire population is that the majority of these patients actually have some occult coronary abnormality to explain their symptoms. So endothelial dysfunction was found quite commonly in these patients. Microvascular dysfunction a little less. We used IMR as our cutoff. When we looked at CFR, it was actually even lower. There were a few patients that had this diffuse disease with a low FFR, but that wasn't generally the main problem. Myocardial bridging was incredibly common in these patients, and the trick is to figure out which ones were just incidental and which were actually causing a problem. But ultimately, only about a quarter of patients couldn't find anything. And there's a good chance they have something we've just never even heard of yet, because they all, again, have symptoms. If we looked at these, there was a lot of crossover in the abnormalities, right? People didn't necessarily just have one. The most common was that we saw patients with myocardial bridging and endothelial dysfunction, and it's well known that patients develop endothelial dysfunction within these bridges, and which may be one reason why they don't cause symptoms until later in life, even though people are born with it. So if we look at the actual sex differences in terms of endothelial dysfunction, we found that there was no sex difference in the presence of having endothelial dysfunction, but men had a longer length of endothelial dysfunction. So this was the same thing that was found by the Mayo group several years ago. When we looked at plaque and FFR, we found that the plaque burden was higher in men. So again, similar to the Mayo group. There was no difference in the FFR values, and there was no difference in men or women having a significant FFR. In terms of myocardial bridging is actually more common in men than it is in women. And then microvascular dysfunction kind of came out as a more interesting, I think, finding because, again, the underlying assumption was that women have more microvascular, I have 3 minutes, I'm almost done, have more microvascular dysfunction than men, but in fact, we found no sex difference in terms of microvascular dysfunction. There seems to be a trend here, at least in terms of these bars, although the p-values don't necessarily reflect that. I mean, it may be that if we do 1,000 patients, we will find more microvascular dysfunction in women. More specifically, the IMR was not different between these, but we did see a lower CFR. And this is interesting because the Mayo group, as I showed you, showed a lower CFR as well. And the WISE study looked at CFR, and they found a lower CFR too. And so the assumption has been that if you have a lower CFR, then you must have microvascular dysfunction. But when we look at what we think is even better measure of microvascular dysfunction, we don't see any difference. So I think the question may come down to, have we kind of been misunderstanding this because of using CFR? When we look at CFR, so this was another one of our postdocs looked at this, and CFR is, as I showed you, is measuring flow during hyperemia as well as at rest, whereas IMR, everything's done at hyperemia, and so the coronary is in one state. And at rest, the coronary vessels are actually quite variable. If you speed things up, if you stress people out, it's quite variable. And so it may be that there's some difference in terms of this baseline value. And what we've seen is that women have a higher resting coronary flow than men, where there's no difference in this hyperemia. So it's probably that women have this lower CFR because they have this higher resting coronary flow. And so the question is, why do they have that? And does that actually cause some sort of pathologic issue down the road? Because we do know a lower CFR is associated with worse outcomes. So some limitations of this data are that we've only looked into the LAD, and so you could have these in the other vessels, and we haven't investigated all vessels. We don't have controls because I can't get normal people to let me do this to them. So there's variations in the definitions and methodologies used. Like I said, like we looked at IMR, other people have looked at CFR, so it makes it a little harder to compare. And we're still waiting on our follow-up data to see if things like IMR actually predict worse outcomes. So overall, women are more likely than men to have angina in the absence of obstructive disease. However, when these women are compared to similarly presenting men, there's no difference in the presence of endothelial dysfunction. Men have a greater length of endothelial dysfunction as well as more plaque burden and myocardial bridging. There's no difference in the presence of microvascular dysfunction, although women have a lower CFR and a lower resting mean transit time. So ongoing sex differences research is certainly needed to replicate these findings and to better understand this whole population. One of the big places now we need to look is what about treatments and helping them feel better. So with that, I'll conclude and take any questions. Thank you.